On count of five, we'll start the event, sir.
Yes, Roshni, we can start. It is 7 o'clock.
Yes, sir. Hi,
Yeah.
very good evening, everyone, and thank you for attending this webinar. Now, I would like to invite Dr. Sushant Vinakar, sir, for setting the content and take the event forward. Sir, over to you, please.
Thank you, Roshni. Good evening to all. On behalf of Molecular Pathology Association of India, it is my pleasure to welcome all the esteemed faculty members and the delegates to the today's webinar on going beyond PIK3CA in breast cancer, the way forward. MPI has successfully organized a series of webinars, and this is the fourth online webinar of 2025 that we are conducting today. So PIK3CA mutations have been an important milestone in personalizing therapy for hormone receptor positive HER2 negative breast cancer patients. The availability of PI3K inhibitors has opened targeted treatment options for many patients. But as we all know, PIK3CA is only a piece of a larger puzzle in breast cancers. Breast cancer biology is complex. Developing of resistance, limited patient benefit, and emerging new biomarkers compel us to look further beyond PIK3CA at ESR1 mutations, AKT pathway targets, HER2 low disease, tumor mutation burden, and the potential of liquid biopsy to guide personalized therapy in breast cancers. So today's discussion will take us through the exciting advances and help us envision how the next era of precision oncology in breast cancer might. It is my privilege to introduce our first speaker for the meeting, Dr. Anbarasan Sekhar, who is a medical oncologist from ACTRAC Navi Mumbai, Kharghar, to enlighten us by taking a session on Beyond PIK3CA, Advancing Precision Medicine in Breast Cancer Therapy. Over to you, Dr. Anbaran.
Thank you, sir, for this kind introduction. Today, we are going to discuss about what is we are going to see beyond PIK3CA mutation in advanced hormone receptor positive breast cancer patients. So these are my topics of interest which we are going to discuss with respect to hormone positive breast cancer. What is the current unmet need and understanding the biology behind endocrine resistance and what are all the targetable drugs available for PIK3CA, EKT and mTOR pathway. And finally, we are going to summarize what are the other guidelines which are suggesting in this area. So this is with respect to the current scenario. We all know that majority of the breast cancers are hormone positive in nature, and little bit is contributed by HER2 positive and triple negative breast cancer setting. Even in HER2 positive setting, some amount of patients were hormone positive. So close to 70 to 80% of patients are hormone positive breast cancer in nature. In India, the percentage might be less, but still it is the predominant cause of breast cancer in Indian scenario. Coming to what are the drugs which is available for hormone positive breast cancer patient, especially in advanced setting. So the treatment for hormone positive breast cancer setting with effect of with the effect of hormone therapy spanning almost close to 5 to 6 decades. And if we divide the response rate between two clusters, initial 2 decades, we able to see initial 3 decades, we able to see only 3 drugs has been approved in the baseline setting, starting from tamoxifen, anastrozole, and fulvestrant. In the last couple of decades, what we able to see is close to 7 different drugs approved in this scenario, including palbociclib. We have SERD inhibitors, and also we have drugs like inavolisib in this scenario. So with this, we are going to see how this changing the treatment paradigm in this picture. So this is the current standard of practice. We always combine endocrine therapy along with the CDK4/6 inhibitors in this scenario. When it comes to CDK4/6 inhibitor, all the three CDK4/6 inhibitors shown uniform amount of progression-free survival. The hazard ratio is uniformly good. What it has achieved? It has achieved the median progression-free survival close to 2 years in duration. So in a hormone positive setting, we can at least in a relaxed setting that at least 2 years, this drug able to control the disease in this scenario. But the overall survival rate little bit different with respect to different CDK4/6 inhibitor, but progression-free survival is same among all the three inhibitors. Another good factor is the curve stops separating early also. So with the use of CDK4/6 inhibitor along with hormone therapy, we are able to achieve response also early in this population. What is the complication? The CDK4/6 inhibitors are good. Toxicity wise, it is very favorable, and also the efficacy is also much better. But what is the complication? What is the effect we are facing after CDK4/6 inhibitor? With respect to CDK4/6 inhibitor, progression free survival is 24 months. But what as a clinician we are facing is after CDK4/6 inhibitor, there is a rapid risk of progression is there, and there is close to 60% decline in the median PFS when it is used in the second line of treatment. What is the contributory factor for this kind of resistance happening beyond CDK4/6 inhibitor? So we are using two different drugs. One is endocrine therapy, and second one with respect to CDK4/6 inhibitor. We are able to characterize the pathway with respect to endocrine therapy. Probably that is the major contributor for such kind of resistance in this population. With respect to CDK4/6 inhibitor, may not making much impact in this scenario. So we will discuss more with respect to the endocrine therapy resistance in this population. As I mentioned earlier, the real world evidence show there is a high attrition rate and close to 50% of patients going to discontinue the treatment with respect to CDK4 inhibitor due to toxicity, due to progression in this scenario. And most patients maintain quality of life during first line treatment. However, their quality of life also alters because of post second line treatment. Maybe these patients offering chemotherapy is the better option in this scenario also. So there is a huge unmet need when it comes to patients progressing on CDK4/6 inhibitor and endocrine therapy in this scenario. So endocrine resistance is a major factor. We are going to see why the endocrine resistance plays a key role in this scenario. When it comes to first line treatment with CDK4/6 inhibitor along with hormone therapy, 85 to 90% of patients able to maintain the response in this scenario. What happens over a period of time is almost 80% of patients develop some or other part of endocrine resistance during the course of treatment, especially beyond third line. So the endocrine resistance plays definitely a key role in resistance for this population. This is with respect to definition of endocrine resistance. So this is with respect to ESMO guidelines in advanced breast cancer setting. We all know that primary endocrine resistance and secondary endocrine resistance. Primary endocrine resistance is nothing but when the patient, it is little bit more aggressive in nature, when the patient develop resistance in adjuvant setting in less than 2 years of duration or in a metastatic setting within 6 months of duration, we consider as a primary endocrine resistance. Rest all the things beyond 2 years of resistance in adjuvant setting, when the patient presenting an upfront metastatic setting and they progress on endocrine therapy after 6 months of endocrine therapy in metastatic setting is considered as secondary endocrine resistance. So this is how the endocrine resistance is matter. And based on the type of endocrine resistance, that combination of endocrine therapy also going to be slightly different in this scenario because the mutation profile underlying tumor biology also slightly different in this scenario. And there is one more additional entity I would like to highlight over here is endocrine insensitivity. That is nothing but when the patient progress within 2 months of treatment with endocrine therapy in advanced breast cancer setting is called as endocrine insensitivity. They remain resistant to most of the endocrine therapy in this scenario. So continuing with endocrine therapy may not be a good option in this scenario. Coming to the dynamics of the endocrine resistance in metastatic breast cancer population, we always go with first line endocrine therapy. Based on the first line response to endocrine therapy, we classify them as endocrine dependent resistance and endocrine independent resistance. What is endocrine estrogen receptor dependent resistance? When the mutation happening at the level of estrogen receptor itself, ESR1 mutation, we call it as endocrine receptor dependent resistance mechanism. Endocrine independent resistance mechanism has other pathways. It may be because of the CDK4/6 inhibitor pathway, or it could be because of the PIK3CA mTOR pathway. That is the subsequent pathway which derive from the endocrine receptor mutation. So it could be at either level which develop endocrine receptor independent resistance. So this is the outcome summary of the patients who have progressed following endocrine combination therapy with two different targeted treatments. We able to see first line with no prior endocrine therapy with AA and CDK4/6 inhibitor, the PFS is close to 2 years in duration. When we use A as a monotherapy, the progression-free survival is 16 months. And subsequently, we have other drugs like fulvestrant or CDK4/6 inhibitor. Fulvestrant as a monoclonal therapy also plays some or other picture. When we come to the second line of treatment, when we combine fulvestrant as a monotherapy, we see the drop in PFS happening. It varies from 2 to 8 months with respect to the type of combination regimen we use in this scenario. So moving on to the next part, that is targeting the targeted pathway with respect to endocrine resistance. So we know that endocrine dependent resistance happens through the level of ESR1 mutation and non-endocrine receptor dependent resistance happening at the level of PIK3CA, AKT, and mTOR pathway. So this is one slide overview that the key difference between endocrine dependent resistance and PIK3CA mutation is PIK3A mutation or AKT or mTOR pathway mutation can happen at the baseline also when they develop metastatic breast cancer setting. Even at the time of setting also they have these kind of mutations, and the prevalence of the mutation is close to 30 to 40%. It may not be varied, so that is the reason we prefer PIK3CA mutation testing at the baseline biopsy sample also. And it can be sometimes co-occurring also. So 0.7% patient have AKT along with PIK3CA mutation, and 2% patient have PIK3CA mutation along with mTOR mutation in this scenario. Approximately 50% of patients have this PIK3CA, AKT, or mTOR pathway mutation. 40% contributed by PIK3CA, and 5% contributed by AKT, and 5% contributed by mTOR pathway mutation. And this is with respect to different studies showing analysis of presence of PIK3CA, AKT, PTEN mutation in this pathway. So this is with respect to the how the drug travels through the from the cellular level, receptor level to the nuclear pathway. So we have the growth factor, estrogen receptor going through there. Whenever there is a mutation happening at the level of ESR1 mutation, we call this ESR1 mutation. That is where the target therapy going to bind and act. And it can happen at the level of below the level of pathway also. When the receptor is going to bind, it activates the PIK3, AKT, and mTOR pathway. So mutation happening at this level also contributory pathway for the resistance in this scenario. So we all know that alpelisib is the key contributor for PIK3CA kind of mutation, and capivasertib is going to target with respect to the AKT mutation, and inavolisib is again targeting newer drug with respect to the PIK3CA mutation. We all know that inavolisib is a very good drug with respect to the PIK3CA kinase mutation, which is a newer drug with lesser amount of side effect profile because of its higher affinity to the PIK3CA mutation. And everolimus acting at the level of mTOR pathway. Coming to the PIK3CA mutation, alpelisib is a key drug. The drug which is showing good amount of response, median PO progression survival is close to 11 months when we combine alpelisib along with fulvestrant post progression on first line endocrine therapy. What is the disadvantage? Why we are not commonly using almost 6 years post the line of approval? Still we are not using alpelisib frequently because of the side effects. So patient will have hyperglycemia, diarrhea, skin toxicity. These are the key toxicities associated with alpelisib in this scenario. Coming to the next important drug, that is inavolisib. Inavolisib is a more specific binder to the PIK3CA, so the side effect profile might be comparatively lesser. That is the idea behind it. And one interesting key thing is they started to use in a much higher setting also. So they started using when the patient is not having any prior line of therapy in advanced breast cancer setting, when the patient has progressed in within 12 months of adjuvant endocrine therapy. So basically, they taken the population of primary endocrine resistance, even the primary endocrine resistance, those who develop resistance within 1 year of duration, they are taken into this scenario. So they taken one of the high risk subset into the population. And key thing to note down is the patient fasting blood sugar should be at the control. Then only this patient has been taken into the study design. They have been randomized into inavolisib, palbociclib along with fulvestrant. So we are moving from the part of double drug regimen in the first line setting to a triple drug regimen with the invent of inavolisib into this scenario. And the key stratification factors include visceral crisis, endocrine resistance, and based on the regional progression has been taken into the scenario. So these are the key endpoints with respect to the inavolisib study, that is Innovo 120 study design. We able to see the improvement in the median progression-free survival. Here it is catching up to 17.2 months. What we seen with alpelisib is 11 months, but the population is not so specific. Here it is one of the highly aggressive population. Even in this scenario, the median progression-free survival is close to 17 months. Be able to see in this scenario, which is likely significant. And second thing, overall survival advantage is also there. With the use of inavolisib in this scenario, the median overall survival is close to 34 months in this scenario. And side effect also comes with this population. Grade 3, grade 4 side effect close to 90%, which is often seen with triplet combination. And the side effect profile is contributed because of CDK4/6 inhibitor, also with respect to the targetable mutation in this target therapy like PIK3A or AKT inhibitor in this scenario. So important thing to note down is serious adverse events seen in 1/4 of the population, but the major thing is contributed with respect to the palbociclib. Close to 14% of patient discontinuation seen with inavolisib and 40% of drug discontinuation is seen with palbociclib. So the side effect profile is mainly because of the triplet combination, and the drug toxicity profile which is limited to PIK3CA inhibitor like skin toxicity, diarrhea, and hyperglycemia episodes are much lesser compared to the alpelisib. Coming to the next in part of target therapy, that is capivasertib. Capivasertib comes at below the level of PIK3CA level at the level of AKT level of inhibition. So we have several drugs to act at the level of capivasertib. We use selective estrogen receptor downregulator, and second thing with respect to the AKT, which is a potent inhibitor of this pathway. The capivasertib has been comes into the main clinical practice with respect to Captillo 219 study, where they included the population with uh, at least 2 lines of endocrine therapy or less than that, 1 line of chemotherapy in the advanced breast cancer setting. Whenever we are using the second endocrine pathway, we need to note down 3 important features. One is whether the patient has used prior CDK4/6 inhibitor in the first line setting or not. How many patients with visceral crisis has been taken into the study design? What is the percentage of patients who are having key resistant pathway mutation in this study population? So, with respect to Captillo 291 study, 70% of population had CDK4/6 exposure, and 60% of population had secondary endocrine resistance, and 40% of population had AKT pathway alteration. And another key important feature in this study design is the duration of the study usage. Capivasertib is used as a 400 mg twice daily, 4 days on, 3 days off. This is one of the important features to highlight because this 3-day off will give us a good amount of the recovery time for the patient to recover from the toxicity for the patient. So that is one of the important feature with respect to capivasertib. It is not a daily dosage which we see with other drugs in this scenario. And the primary endpoint over here is dual primary endpoint. One, the PFS, which is for the overall population, and second endpoint is with respect to the AKT pathway related mutation in this scenario. Coming to the primary endpoint, median progression-free survival in overall population is 7.2 versus 3.6, and the hazard ratio is 0.6, which is clinically significant and statistically significant. When it comes to the pathway altered mutation, here also it is much significant. Coming to the different types of alteration, when the patient is having PIK3CA alteration, AKT alteration, and PTN alteration, what is with respect to the usage of capivasertib in this scenario? It is performed uniformly well across whether the patient has been PIK3CA alteration or AKT alteration or PTN alteration. It is showing good amount of response in this scenario. Coming to the conclusion with respect to the therapy, when it comes to first line endocrine therapy, still now we are going to go ahead with the respect to CDK4/6 along with endocrine therapy in this scenario. When it comes to second line treatment, there comes the change of practice. Preferably go ahead with NGS or PCR testing in this scenario. Try to identify what is the biological mutation happening with respect to the population. Whether the patient is harboring germline BRCA1 or BRCA2 mutation, or the patient is having any endocrine therapy mutations like endocrine pathway mutation like ASR1 mutation or PIK3CA or AKT or PTN mutation in this population. Accordingly, we can decide second line target therapy in this population. Unfortunately, we are not having the drugs in this scenario, but if we able to have the drug, we currently able to use this in our population setting also. But if the patient is not feasible for the second line target therapy, then obviously we can look beyond the target therapy, like going with respect to CDK chemotherapy, which is the conventional option in our scenario, or we can consider newer option like based on Destiny 06 or 04, TDXD also comes into the practice. But the concern is if you use CDK4/6 TDXD in this scenario, what is the next line option? That is a great question. So that is how the progression after CDK4/6 inhibitor along with endocrine therapy in hormone positive breast cancer scenario in our current practice. And this is coming to the last summary of the study design. As I mentioned earlier, ESR1 mutation, which happens but when the patient is on endocrine therapy, over the period of time, this patient usually develop this sort of mutation. Before introduction of any endocrine therapy, the mutation alteration is only 5%, but after exposure to endocrine therapy, it goes up to 40%. This is not the same with respect to PIK3CA, AKT, or PTEN pathway mutation. This can be seen at the baseline also. It is approximately 50% of population. And mutation dynamics, as I mentioned earlier, prolonged endocrine therapy is a causative factor for ESR1 mutation. And ESR1 mutation is a negative prognostic factor, but the pathway PIK3CA, AKT, and PTEN, it is an aggressive feature in this scenario. Good thing is we are having targetable mutation for such kind of scenario in this scenario also. Like in lung cancer, we are having a targetable therapy in this scenario, but the magnitude of benefit will we expect similar to the lung cancer over a period of time only will tell this answer. And currently, the guidelines are recommending to go for testing for PIK3CA, AKT, and PTEN whenever feasible, at least in the second line setting or recurrent setting in this population. And key summary: HER2 positive breast cancer is a complex heterogeneous disease, and it is a dynamic field because the mutation can happen at the level of ESR1 mutation at the level of receptor level or at the level of pathway also. And the key thing is CDK4/6 CDK endocrine therapy is in the first line. When the patient recurs, try to test for NGS testing or TCR mutation. Look for the targetable mutation. If the targetable mutation is there, then try to consider utilizing this targetable mutation in this scenario. I think with this, I would like to thank sponsors and organizers for giving me this opportunity. Thank you.
Thank you, Dr. Anbarasan, for providing us the causes of resistance in hormone receptor positive, HER2 negative breast cancers, explaining their biology of resistance, and updating about the therapies available for patients who are identified with PIK3CA, AKT1, and PTEN alterations. So I would request delegates to post their questions in the question and answer tab that is there available besides the chat tab that is there. Now, from Dr. Anbarasan, we have an idea about the treatment options available. However, before the treatment decisions for biomarker testing, it is important to understand how to test for the biomarkers and which biomarkers to test and what techniques or platforms are to be utilized. For that, let me invite Dr. Trupti Pai, who is a professor, Department of Pathology, Tata Memorial Center, Mumbai, to take a session on integrated PIK3CA, AKT1, and PTEN testing for optimizing breast cancer care. Over to you, Dr. Trupti.
Thank you, Dr. Sushant. So can I share my slides?
Sure. Yes, please. Yeah, your slides are visible.
Is it
Yes.
okay? Fine. Then I
Please
will.
go ahead.
So, yeah. So next 15-20 minutes, we will see again. There will be some repetition from the first talk, like about what is the prevalence, what are the basic means of testing, which are the common mutations, and why we should test those. So the plan of the talk will be like to understand the impact of this PI3K alterations in HR positive, HER2 negative metastatic breast cancer. What is the prevalence of these alterations, disease characteristics and survival outcomes, and then coming to the testing in breast cancer, when and how to test, and then we'll see what is the summary. So now in breast cancer, we are very well versed with the PIK3CA alterations. But now we will see about the entire pathway, that is the PIK3CA, AKT, and the PTEN alterations. So we know that the progressing breast cancer is often associated with signaling pathway overactivation, and this is the most common pathway activation that we see, that is the PI3K AKT pathway. Now, what happens with this pathway activation is that there is increased cell survival and proliferation, and ultimately this leads to resistance to chemotherapy or the targeted treatment. So here we see there is two activation like PI3K and AKT, and PTEN will be the inhibitory gene. So anywhere there will be loss of function of PTEN will also activate this pathway. And what else, if you like inhibit this pathway, there will be downstream activation will be stopped. So this is what we see from this flow chart. Now, this PI3K AKT pathway can be overactivated either by the genomic alterations or by the non-mutational escape mechanisms. So first we saw that anything where there is activating mutations in PIK3CA or AKT, or there is loss of function of PTEN, will lead to activation of pathway, or else there will be some activation of the membrane tyrosine kinase receptors, or there will be overexpression of growth factor receptors like EGFR, FGFR. Everything of this, what it will do, it will cause the overactivation of this pathway. And in PTEN, we will see either there is a loss of function alteration or the loss of protein expression. So the alteration in PIK3CA, AKT, and PTEN can cause overactivation, leading to tumor growth and treatment. So These are the main alterations that we will look into it. So, as is already discussed, this is seen in up to 50% of the patients of hormone receptor positive and HER2 negative advanced breast cancers. So, of this 50, approximately 40 is the PIK3CA alterations. And we know that in PIK3CA, the hotspot is mainly seen in the exon 9, that is the helical domain, or in the exon 20, that is the kinase domain. So, more than 80% of the mutations are seen in these two domains, and rest approximately 5% each of AKT alterations and PTEN alterations. So the literature analysis show that PIK3C is the most prevalent alteration occurring between 20 to 50%. So if we see, different studies have like shown the prevalence of approximately 21 to 51% of the advanced breast cancer. And what about AKT alterations? So it is around 3 to 5%. So these are the different studies which shows the prevalence of 3 to 5% of the prevalence of AKT alterations. And coming to PTEN alterations, it is broad range from 2 to 13% again. So very few studies have done and looked into it. However, the prevalence is 1.8 to 13%. Now, what about patient ethnicity and geography? Is there any impact of this on the PIK3CA alterations? So, the meta-analysis has shown that the PIK3CA alteration prevalence can differ among predicted genetic ancestries, ranges from 48% in South Asian to 37% for African. And also, if you see, there are a higher rate in the Chinese and Asian patients as compared to US and European patients. This is about the PIK3CA, and we know that there is a very limited and the upcoming data on AKT and PTEN alterations. So the numbers are too small for any conclusive evaluation as of now. Then to see if there is any concurrence of this alterations, co-occurrence of this alteration, or all of them are mutually exclusive. So if we look at these three genes, we see that there is a co-occurrence of approximately 2.2% with PIK3CA and PTEN, and very less with AKT and PIK3CA. So there are chances that PIK3CA and PTEN may co-occur. So what about ESR1 mutations? So ESR1 mutations co-occur with PIK3CA more frequently than with AKT or PTEN alterations. But we know that the ESR1 mutation accumulate over a disease course after a prolonged estrogen treatment, and then the timing of mutation may impact the prevalence data, because rest of this can be present at the baseline. However, this is over a period of time in the metastatic setting. Nevertheless, the incidence of co-occurrence is between 10 to 49%. So what are the other potential biomarkers to co-occur with PIK3CA, AKT, and PTEN alterations? So, so there are another group of biomarkers, like you do homologous recombination, or there are predictors of IO benefit, and then there are other mutations. So if we see that in the incidence of this alteration in non-altered PIK3CA pathway versus different altered mutations in different genes. So of this, significantly we see that the BRCA1 alteration is decreased whenever the tumor is PIK3CA altered, whereas the incidence is increased when it is a PTEN altered. Similarly, TMB high incidence is more with PIK3CA altered subgroup and PIK3CA PTEN altered. So what does this show? That now it is not a trend for a single gene testing, but it is better if you do NGS testing, because there is co-occurrence of different alterations, and also these are having different therapeutic implications. So the question comes as to when and how to test it. So what does the guidelines have to say? So if you see the NCCN guidelines, it suggests that the assessment of PIK3CA or AKT or PTEN alterations with NGS and on tumor tissue or on blood sample. But if blood sample is negative, you have to test the tumor tissue. Assessing PIK3CA status with NGS or PCR blood samples or tumor tissue. So whenever the blood is negative, if you are testing blood is negative, you have to test the tumor tissue. Then the ASCO guidelines say that the routine testing for activating mutation in ESR1, PIK3CA, AKT, and inactivation of PTEN is must. ESMO guidelines also shows that the tumor NGS of a tumor or plasma is necessary, and it determines the AKT PTEN alteration in addition to PIK3CA. It can provide the drug access to these patients. So when do we test it? This testing at metastatic diagnosis is essential. So you may not test here, but whenever there is initial like diagnosis at the initial metastasis, you can test at this time. Even if the treatment is eligible for second line, you can test at the time of metastasis. So in general, if we see, NGS is generally recommended for patients with advanced breast cancer that are eligible, because you are assessing different pathway alteration. It is not just a single gene testing. So why is NGS recommended? Because it is definitely more efficient, less expensive, and than single gene testing, and it is a high throughput. So it gives you information about other alterations also, which has different diagnostic and prognostic information. And also it determines the eligibility for different targeted therapies and for clinical trials. So in one go, you get the assessment of various different alterations and genes. So when is it recommended? It is recommended at the time of metastasis or on progression. So in contrast to ESR1, which accumulate over a period of time, PIK3CA are largely stable, and it is important that you test it at the time of diagnosis. So as we see that these alterations are seen even at the baseline. So for the testing, you can take a primary biopsy as well as the metastatic. In ESR1 mutation, because it was mainly seen in the metastatic, whenever you do testing, you will focus on the metastatic side. For other cytology sample, so whenever you are using cytology sample, just check the cellularity. If you have less cellularity, you can combine 4 5 slides and then scrape the cells and do it on that as well, but you have to be cautious that it has sufficient cellularity. So there are variety of commercial testing kits available for detections. So you have Avenio, you have Illumina, Thermo Fisher, Sophia Genetics. So different these platforms are there. Illumina, Nexic, then you have Ion Torrent pathway, then you have Genexus system. So there are various platforms which are available from which you can do this testing. So Capitello 291 trial, what does it included? Gene mutations of at least one qualifying alteration in PIK3CA, AKT, or PTEN genes. The technology used was NGS, and the assay was Foundation 1 CDX assay. So, what are the different alterations that were taken into consideration? So, in AKT, there were various short variants. So, any short variant with protein effect, so this is considered as a hotspot, E17K. For PIK3CA, there were many short variants. So, all is like a single nucleotide variants. So P10 is little difficult because here you have copy number variations, you have nonsense mutations, you have frame shift mutations, you have a variety of different alterations with P10. So all of these were included. So we are in this era of liquid biopsy and ctDNA. So what is the concordance between tissue biopsy and liquid biopsy? For if we see at the PIK3CA detection, even for this PIK3CA detection, you can see the concordance varies from 55 to 72 to 100%, and it depends on the which platform you are using. More sensitive platform you are using, there will be high level of concordance, but then it gets very expensive, and so that is the thing. So basically for these alterations, it is better to do on the tissue biopsy. So there was an exploratory analysis of PTEN deficiency by IHC also. So we saw that in PTEN there are variety of different alterations by NGS which might get missed. So what if we do IHC just to see like what is the feasibility of identifying PTEN deletions on IHC? So this is like a normal control on colon. So what is the expression pattern that we see? We see either a cytoplasmic staining diffuse, or we see a membranous, or sometimes you will see a nuclear. So that is like a normal staining. And what happens when there is a PTEN deficiency or loss? Here you say the intervening stroma is showing staining lymphocytes, vascular endothelial cells, but the tumor is showing loss of staining. So that is very important. Now depending on what criteria is used for deficiency, in literature some people used to say that complete loss of expression. Then some where then there used to be a scoring. So score 1 will be like, compared to the normal cell, how less is the staining. So there might be a mild cytoplasmic staining, that was labeled as score 1. So depending on that, different studies have utilized different criteria. Now in this analysis, the criteria used was more than 90% of malignant cells with no cytoplasmic staining. So this was the criteria which was used for this trial. And with this we see that median progression free survival was 9.3 months, as against with placebo it was 3.7 months. So it was still a very significant finding. So with this, was there any concordance between the NGS PTEN's status by NGS and by IHC? So we see that the PTEN altered by NGS in this subgroup, at least only 72% shows loss of PTEN by IHC, whereas in 28% it was still proficient. And in the PTEN non-altered by NGS, we can see that the 11% showed deficiency by IHC. So basically, the PTEN testing with NGS and IHC is not always concordant, but individually, if you see, both have a significant change in the progression-free survival. What if we use liquid biopsy for PTEN testing in breast cancer? So if you overall see for this pathway alterations like PIK3CA, we saw that it was around 55 to 72%. In this AKT, P10 and all, you see that the tissue biopsy, at least you will get a prevalence of 3 to 5%, but liquid biopsy in this study had hardly any cases that showed. Also, because copy number variations in CGP and in liquid biopsy, you need very higher tumor content as compared to AKT alterations, which are usually short variant mutations. P10 are usually large deletion or maybe a copy number variation. So if you just alone use liquid biopsy, you might miss on this P10 alterations. So NGS tissue on tissue biopsy is the best method to test for all the PI3K pathway alterations, especially P10 when compared with the liquid biopsy. So to summarize, we saw that approximately 50% of patients with HR positive, HER2 negative advanced breast cancer harbor these alterations. This prevalence vary according to the geographies and the ethnicity. However, these are largely stable across the disease course. ESMO, NCC, and ASCO guidelines recommend testing for these alterations. And why do we test this? To identify patients eligible for capivasertib with fulvestrant. Testing is done at metastatic diagnosis, and currently approved test for this alteration is NGS based Foundation 1, which is adopted in US. However, other labs like across rest of the world, other NGS based lab developed tests are likely to be adopted. So this is a new testing pattern, so we are not well versed with it. So most of the NGS panels have this AKT and P10 alterations, but hardly ever we get requests for this. So now maybe with this trial results and all, there will be improvement in testing. Okay, with this I would like to end my talk. Thank you very much for patient hearing, and thank you all the organizers for giving this opportunity. Thank you.
Thank you, Dr. Trupti, for the excellent session. You very well highlighted the biology of PIK3CA, AKT1, and P10 alterations and updated us about the guidelines and the recent recommendations for testing of these biomarkers and the platforms that are available for testing of these new biomarkers in breast cancers. So, delegates are requested to post their queries in the question answers tab, which is present just besides the chat tab that is there. Now that we have heard about the medical managements and the testing strategies for this new biomarkers in the breast cancer, let us move to panel discussion and hear from the experts in this field on the viewpoints on biomarker testing in breast cancer and their utility in the real world scenario. So I would like to invite Dr. Trupti Pai again to moderate the panel discussion on integrated PIK3CA, AKT1, and P10 testing for optimizing breast cancer. For panel discussion, we have esteemed panelist Dr. M. Santosh Reddy, who is a medical oncologist from Omega Hospitals, Hyderabad. Again, Dr. Annabrasan S. from a medical oncologist from ACTRAC, Navi Mumbai. Dr. Rekha Pai, who is professor, Department of Molecular Pathology, Christian Medical College, Vellore, and Dr. Suruchi Agarwal, who is head of scientific affairs at Strand Life Sciences, Bangalore. So over to you, Dr. Trupti Pai, for moderation of this panel discussion.
Yeah, thank you very much. So I would like to invite all the panelists. So can I share my slide?
Yes.
Okay, it's visible, right?
Yeah, it's visible, but it's not in the slideshow
Is it?
format. Yeah. Can you make it into the slide
Just a minute. Huh?
format? Yeah.
I think I will stop sharing and again. Okay, is it now visible?
Yes.
Yes.
Okay.
Please go ahead, Dr. Trupti.
So now we saw the medical part and the testing part, and we know this is a new biomarker. So let's ask our experts about what is the current testing landscape and what are the expectations and what are has the practice changed over a period of time. So this first question is for Dr. Anbarsan. Like, what all molecular testing routinely you do in breast cancers? Dr. Anbarsan, Dr. Sushant, is Dr. Anbarsan there?
He's away
I
in the
don't
meeting. I'll
see
just
Okay,
him.
sorry. Okay, Dr. Santosh is there.
Yeah, ma'am.
Yeah. So can you
Good
please?
evening, everyone, and thank you for giving me this opportunity. Yeah, coming to the question, what are molecular markers in breast cancer do you really do? Definitely, hormone positivity, right? ER, PR, and HER2, which KF67, along with in the metastatic setting upfront. So definitely, I'll be ordering NGS for PIK3CA, and upon on disease progression after the CTK4 inhibitors along with the AI, I'll be ordering ESR1 for sure. And if it's possible, like PIK3CA, P10, and AKT.
So this you are routinely doing currently, like in your practice?
Right now, like after the disease progression in the first line setting, like CTK4 plus AI, after the disease progression only, I'm entering into the PIK3CA route.
Okay. So do you prefer real-time PCR or NGS directly you are using?
I'm using NGS directly now.
Okay. And how frequently, how many cases do you ask for? Like maybe in a week?
In a month, around max 4 cases in a month.
Okay. Okay. Dr. Anbarsan is there? No?
Uh, Good evening, ma'am. I'm here.
Yeah, yeah.
So,
Can you tell me what all molecular testing in breast cancer do you routinely do?
ma'am, in a metastatic breast cancer setting, if the patient is in a younger age group, we consider for germline testing. So most of the time, we consider germline testing for the patients. Yeah, that is standard. And apart from that, we start with CDK4/6 with the endocrine therapy. If the patient in a recurrent setting, in those situations, we prefer to do this PIK3CA, AKT, and all those things. But initially, PIK3CA was only the targeted therapy available, alpelisib. So we try to do with RT-PCR for PIK3CA mutation, those patients who are affordable for PIK3CA inhibitor. Otherwise, we don't recommend molecular testing routinely for the patient. But recently, based on the newer approach and newer treatment guidelines are upcoming, so we are also changing our practice little bit more to testing for NGS. Especially, we started doing comprehensive gene profiling. So, and the price difference is also not much compared to the normal genetic profile NGS panel. So we started using CGP more in this scenario currently. And
Okay.
I'm also going through these studies. They also prefer more liquid biopsy. So Serena 6 also used more liquid biopsy in this scenario for detecting ASR1 mutation. And also this Innovo 120, where they tried for Innovolisib, they're using more of a liquid biopsy. So preferably we are trying to do with liquid biopsy in this population now.
So yeah, I think the practice will change. But currently, like for PIK3CA, real-time PCR was what was done. But now with this trial data and all, we are more towards liquid biopsy and comprehensive.
Yes, ma'am. We started changing practice now.
Okay. So for ESR1, we look for liquid biopsy, but for this P10 and AKT, mostly tissue biopsy will be more better. Okay. So this is for Dr. Rekha. What triggers biomarker testing? Reflex at metastatic, or you do only when you get requests from the clinicians?
Uh, as of now, we don't have reflex testing at all for as far as breast cancer goes. It's hugely and largely based upon a request. But the request patterns these days are changing. Earlier, they were few and far between, but now I can see that with this data flooding in, there's been there are many more requests that come to the lab, and again, just to go back to that point, whether NGS would be preferred, whether PIK3CA can be done by other methods and all that. So there was a point in time when alpelisib patients who would want to receive alpelisib, we used to test them by a ddPCR, and there was no requirement to do an NGS in that scenario. But now even that is changing, because everybody wants to know not just about PIK3CA or a hotspot driven analysis, rather to move to looking at the whole gene and to look at PIK3CA, AKT, and PTEN alterations as well. So I think the whole scenario is changing with all the data flooding in.
Yes.
Ma'am, one more thing to add on. Apart from this targetable mutation, another purpose for doing repeat biopsy, especially in this scenario, is to look for the HER2 status. If the patient baseline HER2 is 0, we want to confirm whether it is 1 plus or 2 plus, because the destiny 04 and 06 also slowly we are catching him. So that is also one reason we have started doing increasing number of biopsy in the recurrence setting.
Yes.
Previously, we are not suggestive of any repeated biopsy, but based on the newer target therapies and the newer antibody drug conjugate, the biopsy frequency also increased.
So basically on biopsy, like to assess HER2 low, ultra low status and molecular for all these alterations.
Yes, ma'am. I think today the guidelines also released from ESMO in advanced breast cancer setting to look for repeat biopsy in this scenario, especially in hormone positive breast cancer. What are all the markers we need to check? In a TNBC, what are all the markers to check? So they have also recently updated the guidelines.
Okay. So mostly that will be in second line, no? So even if in this spectrum you get HER2 low or ultra low.
Yes, ma'am. In second line, yeah.
Yeah. So for Dr. Suruchi, is AKT and PTEN routinely assessed in your lab?
Like as we heard till now, that definitely the practice is changing. So the AKT1 and P10 is usually the part of the broad panel testing. And when we do get the samples for metastatic breast cancer, then these are being tested. However, from last few months, we have started getting the focused requests for these four genes, PIK3CA, AKT1, P10, and ESR1 in the metastatic settings. So I wouldn't say routinely as of now, but yes, because these are the part of comprehensive genomic profiling, and when all the lines have exhausted, so at metastatic lines, mostly CGP is ordered for breast cancer for the patients who can afford genomic testing. So definitely these two genes are tested.
Okay. And any experience on positivity rate? Like you have done comprehensive, and what is the
Yeah,
prevalence
so
of?
I think the positivity rate is below 5%, below 3 to 5% only for AKT1. For P10, it is little bit higher, 4 to 7%. AKT is below, I think, 3%. And PIK3CA is around 40%. And ESR1 varies from 3 to 10%. So, yeah,
Okay. Same is seen in your setting.
yes, yes.
Okay. And what about IHC for PTEN?
IHCs for P10 has not been requested very routinely as of now. And sometimes we do see IHC reports that we get with the tissue and P10 loss is indicated by IHC. However, they are not sent along with next generation sequencing to check P10 IHC. So P10 loss, if that is found on next generation sequencing, is reported as such without any reflex confirmation or additional IHC.
Actually,
Dr.
I
Rekha,
think
would you like to?
I
Yeah.
can just add a bit here. IHC has actually been looked in the realm of these trials mostly. Outside of trials, people keeping it as a routine
I
practice
do agree.
has not been something which is around. But I think with the requirement coming up, gradually every lab is trying to calibrate quickly to it, and there will
Yeah.
be more of it being offered in future. Yeah.
Yes, and even in gynec tumor, there is a lot of significance of this. So if we develop, it would be better, I guess. So the NCCN guidelines we saw.
Alterations
Yeah,
actually can be seen across tumors.
Yes,
So, therefore, the need to develop it is acute. Yeah.
it would be good if we develop this.
I
So
think the protein expression, looking at protein expression is always better, and that gives us much more confidence. That's what, yeah.
yes, agreed, agreed. So compare the real-time PCR versus NGS versus. Which are the panels that you are using currently, Dr. Rekha? NGS panels.
So, one of the most frequently ordered panel is a small panel called Oncomine Focus, which is something which is very quick to do, rapidly used, etc. But it does not have the P10 alterations. We can't look for P10. So, considering that, the what is called the Oncomine Comprehensive Assay 161 is the next best thing. And now we've also started offering CGP, which is called OCA Plus. So these are the compendium available with us. And I think the most preferred one right now, because it gets as comprehensive as possible, but at a lesser cost, is the OCA 161. So this is all the oncomine set of um, testing range that I'm just listing out.
And how much is the cost difference, like in your different panels?
So we try to keep the focus as less as possible. It is at least 50% lesser than OCA 161.
Okay.
Yeah.
Okay. So for the clinicians who are asking for this, like they have to be sure, because there will be some panels which will not have either of this alteration. So what is the clinical need for that particular patient? Depending on that, we have to ask for a NGS. So comprehensive is there, but sometimes it might get expensive. But there are definitely even short panels like 50 genes, and it will cover all these alterations. The comprehensive, the advantage will be like it is like hybrid capture and entire exonic region, so you will not miss on any alteration. Another thing, when you are looking at p10, you have to also look at the copy number variation, not just SNVs.
Dr. Dupti, I would like to
Yeah,
add to
yeah.
this
Yes.
question. So basically, I understand there are some pre-made panels like Dr. Rekha Pai indicated. However, the labs who are using Illumina technologies, so apart from the CGP, which is offered by Illumina, that is TSO 500, these labs, they have in-house panels also. So those are custom hybrid capture panels which do cover these genes adequately, and the validations and CAP accreditations are in place. So both for solid tumors as well as, I mean, tumor biopsies as well as liquid biopsies. So hence these can also be an option.
Yes, so whichever panels you are using, we should make sure that the broader
Coverage.
spectrum, yeah. So like if comprehensive are well off, because the entire exonic region, because if you see there is no as such hotspot, so all these are very new upcoming biomarkers. So if you see some, like if you see the OPA panel thermo fissures for AKT, you have 50, 40 different hotspots. Some other panel will have different, which are like amplicon based. So in comprehensive, you will have a better like exonic entire coverage. So whoever is asking for, they should be aware of what panels they are using. So Dr. Suruchi, are structural variants and copy loss adequately
Yes.
detected by your panel? How sure you are?
Yeah, I think, yeah. So this is a very good question and should be addressed. Structural variants and copy loss, basically, by next generation sequencing, whenever we do, and especially on FFP DNA, owing to the quality of DNA and owing to the limitations of next generation sequencing as such, because it is a short read sequencing method, the sensitivity is not 100%. Even for ERBB2, or we talk about KRAS or EGFR, or like MET, or be it PTEN, right now we are talking for that gene. So basically, there is a intrinsic limitation on next generation sequencing as an assay, because it is a short read sequencing method, as I mentioned. So the validations has to be proper, and even if the proper validation and proper designs are done, the sensitivity remains to be between 70% to 85%. And some of the labs, like in my previous lab, there were orthogonal validations done, and in the current lab also the orthogonal validations are done, where the next generation sequencing concordance is checked with the samples who have been tested with orthogonal methods like IHC or FISH, and still the concordance stat is between 85 to 90%. It doesn't increase beyond that, and that is not due to the lab as such. I would like to emphasize it. That is due to the intrinsic limitation of next generation sequencing assay, and also the limitation of FFP blocks. If you say, if there is a less than 20% tumor content on the block, and if the quality of DNA is bad in terms of DNA integration number and fragment peak size, the copy number variation sensitivity reduces a low, I mean, it reduces the sensitivity for detection of copy number variations. So there are many caveats to it, and we have to understand scientifically and technologically that where do we stand here. So sometimes the lab may report single nucleotide variations with good confidence, but still have a disclaimer in the report saying that copy number variations could not be determined properly due to the poor quality of FFP DNA. And that is the practical scenarios we do see with multiple FFP blocks that we get from different regions in India.
Yeah. So the take home message here is like the CNVs will have some issue on the NGS based, and usually as a pathologist, like fish based testing, we are more comfortable and usually considered as gold standard.
Gold
In this
standard.
scenario, yeah, in this scenario with all these different markers, P10 usually have this loss and this loss and this frame shift alterations and large kind of deletions, which if you just use liquid biopsy, there are high chances that you might miss. So I was thinking like if labs develop like IHC, it will be like a good surrogate, at least to pick this which NGS might miss. So
Yeah,
that
liquid biopsy, we should not go for copy number variations as such. I don't think we do have any concordant study or any good assay as of now to determine copy number variations with utmost sensitivity on liquid biopsy, because the fragments are still shorter. So,
yes.
I mean, we know the technological caveats here, and I think we should not just go by what is being talked and what is being offered off the shelf all the time.
I think in context,
Ma'am, I have a
it's only ESR1 which has actually picked up in context
Exactly.
of liquid biopsy, and I
Yes.
think it stays there
Yeah.
because of the limitations of doing in a liquid biopsy and the depth that you require.
Yeah.
I don't think it is possible to look at alterations with that level of
PIK3CA is
confidence.
also fine. PIK3CA
Yeah,
is also
PIK3CA
fine
is
on
okay,
liquid.
but right now the data available is always driven towards ESR1 and monitoring ESR1,
Exactly.
especially in context of endocrine therapy and resistance.
Yeah.
Correct. Agreed. Yes, doctor.
Yes, ma'am. I also would like to comment on the same thing only, ma'am, because PIK3, AKT, and P10 are present at the baseline only. So even if we do the testing in a baseline sample, it will be okay to diagnose this mutation. Only requirement comes for ESR1 mutation because it is a dynamic marker. It can change at any time. With the Serena 6 study, what it has shown is they try to see the ESR1 mutation at a frequent interval. Even if the patient is not progressing, they try to check the marker every 3 months to 6 months, and then they analyze. They also given a median time where the median peak is to identify PIK3CA mutation. It is somewhere between 6 to 16 months. That is the average time, the percentage of detecting ESR1 mutation.
Yes. That is
So,
also a
So,
very
the
important point.
Serena
The
6,
testing window for ESR1.
I think the Serena 6 showed that the first sample tested at 6 months itself showed 51% positivity for ESR1. So it was
yes,
a very good indicator of the fact that if they are already on ET plus CDK4/6, there's a big chance that the first time itself you'll pick it up.
Yeah, I think the previous webinar highlighted this point very nicely. I think Dr. Amerson was there. So 6 to 30 months was the window for ESR1 testing. Dr. Shaina Dawood, she has emphasized that point. Yeah.
yes, yes. So the window we can able to capture, that will be fine. If you are doing a ctDNA for ESR1 alone, will there be any cost difference? We able to significantly reduce the cost?
So amplicon-based panel along with ESR1 for hotspot mutations, definitely we will be able to reduce the cost. It can be brought down within 10K. But I mean, if we are doing, if we say that no AKT1, P10 and PIK3CA has to be done on the tissue and ESR1 on liquid, then I think both the tests needs to be done. But yes, as you mentioned, for hotspot ESR1 mutations, for that ligand binding domain mutations alone, if we design the amplicon panel, definitely we can bring down the cost.
But Dr. Anderson, we should not look at just ESR1, because in this just now we saw that we have all
That's
the
what, like both the test needs. Yeah.
and at least in DMH we will not like look at the specific just for this, like research purpose is fine, but in routine diagnostics it's better that a short DNA like short target gene where you will have other information also, that would be better.
Yeah.
Yes,
Otherwise,
ma'am.
we
But
are
the
missing both
problem
the
here
tests.
is one marker we are testing is a marker which present from the baseline, and another marker ESR1, which is a dynamic marker. Sometime it may be present, sometime it may not be present. So we need a frequent testing for it.
So
So
frequent testing
probably
For
we need to.
monitoring purpose, amplicon
can
test
do.
is good.
So if you are just looking at single gene, then maybe you can go ahead with ddPCR. That will be more cheaper
Yes, ma'am.
and
Yes,
more
ma'am. That is my
convenient.
next question
Yeah,
also. Like
yeah.
in Serena 6, even though there are multiple hotspot mutation with respect to ESR1, in Serena 6, what they found out is there are only four hotspot mutation, which is present in 90% of population.
So
So whether can
ddPCR and
we,
amplicon based panel, I think should cost the same.
okay.
But I
In
also
in real world setting, like
testing.
repeating
So
number of times ESR1 is very difficult now. Like in real world, it's only in data literature is okay, but counseling for number of times of ESR, it's very difficult in the real world.
Very true. Okay. Uh,
So, can I bring a point over here?
yes.
So, with my experience, even if the cost of DDPCR and amplicon-based NGS is might be almost same, but DDPCR is much faster test.
I was
The
about to
turnaround
point it
time
out.
for
It's a
DDPCR
turnaround time. Yeah.
would be much more faster as compared to amplicon-based NGS sequencing.
Right, yes. That is
Yeah,
there. That
just to
advantage
share
is
my
there.
experience.
Yeah, yeah,
Yeah.
very true. So, Dr. Anvarsan, if you're just looking at ESR1, better to go with DDPCR.
Yes, ma'am. Yes, ma'am. I think it is a difficult test to do, ma'am, because every time when we see there is patient is clinically stable, the challenge of using this target therapy is patient will be clinically stable, but
Yes.
the molecular testing is showing patient is having mutation. That will be a challenge. But one advantage we should not forget is these patient with target therapy may not have ARFol, which is the most troubling complaint for majority of the patient with TDXD, with chemotherapy. Often the challenge is patient will have hair fall. They will be terribly depressed because of the hair fall.
Yes.
Probably this hormone therapy will be good for such working women, those who want hair to be preserved. I think that's a good option.
So,
Uh,
Dr.
and
Maybe
Santosh,
not
ma'am,
in
I
all
want to add
scenarios,
one more.
but in
Like
specific scenarios, we can consider this test.
okay,
And
okay.
I want to
doing
add one
liquid
more,
biopsy
ma'am.
make it be more feasible also.
Yes,
Even
Dr.
the patient is having ESR1 positivity upfront, I'm not going to add any drug, right, in the upfront. So why
So
not?
ESR1 will not happen in upfront setting. That is the beauty of this thing.
It will
ESR1
progress over
always
time.
it happens over a period of time. The Serena
Agreed.
6 study has shown already that if the patient has developed ESR1 mutation during the course of treatment, even if there is no radiological progression, changing the line of treatment has shown PFS benefit. It is actually doubling of PFS benefit is there, close to around 12 months of benefit is there. OS data yet to mature. And the second part of the data is PFS2. PFS2 is also very good for the Serena 6 study.
Right. Agreed. Agreed.
Yes, agreed. Okay, Dr. Santosh, are you confident in acting on now? Like, if you get reports on EKT or P10 results, like, will you?
Uh, PIK3CA, yes, ma'am. PIK3CA, yeah, but I have used alpelisib, yes, okay. But about capacitive and AKT, that I have not used it. So I'm confident only on PIK3CA right now.
Okay, what about you, Dr. Anvarsan?
We have used a SERD and a CERCA in a clinical trial setting. Good thing about this newer drugs is the side effect profile is little lesser. But where we get stuck up is we have to do as a not as a single agent. We have to use always as a combination of treatment. It could be either double it or triple it. That could be a challenging scenario. But when we use more, we able to know what is the side effect profile.
Okay,
And also,
and
ma'am, with PAL-base also, the PAL-base or CDK4/6 inhibitor also, if you see the grade 3 toxicity, it is more than 70-80%. But the neutropenia rate is also close to 60%. But the FN rate is very, very lesser. Something similar to that with the third inhibitor also, I think the patient also prefers such kind of treatment. Then.
so you mean if you get these alterations, you are
If we get the alterations and the drug is available in India, I tend to use it for the patient because of other factors coming into the picture.
okay. So, Dr. Santosh, you said you frequently do NGS. So, tell me what challenges you face with the NGS reporting. Like, if you just get the report, what are the common challenges that you face, Dr. Santosh? Okay,
Yeah,
Doctor.
ma'am. If
Yeah,
yeah,
tell me.
in the NGS reporting, if I get a sure shot marker, like if I'm confident enough, like PIK3CA or AKT, like upfront it's not of a big issue. But if I get some different VUS where I can't like no limited data and no sure shot like marker targeting, then there is a difficulty.
Okay, so what do you do for such cases then?
I'll discuss with the pathologist, obviously. And then because like pathology is also not sure, right? Like because of VUS and all the stuff, there is only very limited data where we can target those genes. So NGS, obviously, yeah, I'm doing NGS, but only the sure shot diagnosis like PIK3CA, AKT, or PTEN. Then only I'm acting on. And other VUS where the no targets for that, just I'll be keeping on observation.
Okay. Dr. Anbarsan?
Yes, ma'am. So key thing I would like to highlight is we are discussing more about target therapy, but we should not forget the role of BRCA1 and BRCA2 inhibitor, especially the targetable drug that is PARP inhibitor is available at a generic versions are available, and it is a reasonable cost also for the patient. So always in patients who are having recurrence, go for germline testing. That is so essential. With respect to NGS reporting, we started recently doing it now more frequently, ma'am, because of the lack of availability of the data. What we do in our practices, one thing we do for PIK3CA mutation testing as an RT-PCR based testing.
Dr.
Second
Anbarsan, challenges with NGS reporting. So you get
challenge is,
NGS
ma'am,
and
we don't
what
have drug, ma'am.
challenges?
We don't have drug now. That is the problem.
Apart from that, in NGS reporting, you don't find any challenges like common issues like BAF is not mentioned, or maybe BRCA1
No,
alteration
ma'am.
at which are the
Our
pathogenic.
report is reliable, more adequate. So we do our in-house panel only. I don't find any other issues. Only thing is, in hormone positive setting, where we find is difficulty is taking the biopsy. Most of the time, this patient will have bone only recurrence. So repeat biopsy will be little difficult for the patient. More of a technical challenge going for a tissue biopsy.
Okay.
Apart from that, I'm finding it is good. With
Okay.
respect to the recent comprehensive gene profiling, we get couple of more pathogenic mutation, tier 1 and tier 2 mutations, like 2 3 mutations are available for the patient. That is the thing I'm experiencing right now.
Dr. Tripti, can I ask
Yes,
Dr. Anbarasan one quick question?
yes, yes, please.
How would you view somatic BRCA mutations that are pathogenic in this specific population? Often enough, you do find somatic BRCA mutations. I'm not talking of germline, but you have sent it to the lab for testing. You're not finding PIK3CA, but you're finding somatic BRCA. And how do you view that?
Yes, ma'am.
Currently, guidelines don't indicate that you treat the somatic, but are you ever tempted because you have no other option in these, or would it be an option to consider?
Actually, there is not much need for attempting a PARP inhibitor for a somatic mutation because the response rate with PARP inhibitor in a somatic mutation alone is only 40%. This amount of response rate we can get with the chemotherapy also. And the toxicity profile is almost similar to the chemotherapy. And we have to continue PARP inhibitor for long duration. Since it is not approved, we are not using for somatic mutation testing. Based on the somatic BRCA1 BRCA2, I'm not changing the line of treatment for such population. And apart from germline BRCA1 and BRCA2, we also look for germline PAL-B2. In
Yeah.
germline PAL-B2 also, the response rate with PARP inhibitor is close to 70%. So if the patient, apart from BRCA1 and BRCA2, if they exhibit germline PAL-B2, I'm adding PARP inhibitor in that scenario.
Thank you.
So, Dr. Rekha, do you think reflex testing would be beneficial? Like if in the current practice we get such scenario and we on our own from lab side, we reflexly do this testing. Do you think that is feasible?
Uh, I think it is feasible, but I think it will take a long time to get there, Dr. Trupti, because if you look at it, it took us a while to sort of calibrate in context of lung carcinomas also to
Yes,
make it into
exactly.
reflex. So now I think most of our labs just go ahead and do it, and it doesn't really wait. We don't wait for the oncologist to tell us. So reflex is certainly on for lung, but I think it is possible even in context of metastatic breast cancer. It is possible to get there, but it might still take a little time. As I've seen in the last few months, there's already a change in practice. There are more cases coming in the metastatic, the hormone receptor positive. There are more numbers coming in for testing, but I think it will still take a little while before there is reflex testing.
So, Dr. Anbarsan, are you happy with this if the lab decides and do reflex testing?
No, ma'am, it will add some more trouble for us if the drug is not available for the patient. So I will counsel and then based on the feasibility, all those factors, taking into consideration, then only I will consider doing this testing.
Yes. So in TMH, neither in lung also, there is no possibility of reflex testing. The request always comes from the clinicians.
Yes.
Yes, yeah. So about sample quality and pre-analytics, these are always the thing. So Dr. Rekha,
Yeah.
so how is your performance in NGS? Like you say, how many times you have to reject the sample because of the quality issues?
So there are two major issues we face. One is tumor cellularity. When it is really low and we know that NGS is just not going to be useful, that's one source of rejection. The other is at first point of screening is when we have actually extracted the DNA, the DIN values are poor. We know it's not going to work. We reject it at that stage. There is also a set, especially some of those mucinous carcinomas. Sometimes, though we've extracted, avoiding necrotic areas, there are issues when it comes to the final QC after NGS. It can still be a problem. Our failure rates are not as high as it's 10% here or over 10% in the trial setting. I think because we are very careful and also we are dealing mostly with samples coming from our own setting where tissues have been handled carefully, where the processing, initial histopathology driven processing is all standardized. Our failure rates are a little lower than this.
Dr. Suruchi, your failure
Yeah.
or rejection rate maybe?
This is like a never-ending topic for all of us, and it's a very important point here. What I have observed in the past few months is that, prostate and the breast are the ones which behave very bad, especially the breast core biopsies. And as Dr. Rekha Pai mentioned, that apart from tumor cellularity, the mucinous carcinomas, they behave really weird. And even if we get good DIN values at the start, I mean, we do fail them at analysis. So of course, here I also agree 10%, greater than 10% is little bit higher rejection rate. So I think 7 to 8% is that what we look at. But yes, unlike Dr. Rekha Pai, we get the samples from multiple centers and multiple places, and the variability is too high. And if I have to basically tell that, which samples do fail more, so I would say that post NAC THRD, I mean, it's not in the context of this particular talk, but definitely if the chemo treated sample comes to us, then the percentage of necrosis is high. And similarly, breast and prostate, especially these two types of cancer types, they are failed more with the poor quality of DNA. And in prostate, even we did this, both in prostate and breast, even we did this analysis where the insert size itself is shorter. When we take it for next generation sequencing, initially the insert size is shorter. So I think we have to be careful about the fragmentation times and other things at library. So we do take care some of those samples. Yeah.
Yeah, so ours is also a referral center, and breast fixation is really an issue. And I always feel that we are in an era where we are scoring like ultra low and everything, and your pre-analytics, like especially in the referral material, is so bad
So
that none
bad.
of, yeah, so resection you have like 10, 15 paraffin blocks of tumor, and none of it is like, it is almost autolyzed samples. So it
Correct.
is almost like, so I feel more than like exotic molecular, there should be sessions on just pre-analytics and large scale awareness for this at every step, from grossing, like cold ischemia time fixation, and this with time and again we have to
I
do
think
this
We
because
usage
have
of
to
nutrient
change the
buffered format.
paradigm towards next generation sequencing testing, usage of tissues,
yes,
then the protein based testing. I
yeah,
think that mindset needs to be changed
yes,
completely, because I'll tell you, here we have lot of participants, and I completely agree with Dr. Trupti Pai. So I have spoken to one pathologist for ovarian cancer. There were 5 tissue blocks I received with one single course in each. So I just asked, like, why we didn't put all the cores in single block, because it would have been much easier for me to. So the answer was that we are doing it for lung, but we are not doing it for ovary. So I mean, I'm just saying, because you're pointing out that yes, the sessions needs from, especially, I mean, from at each and every step. So at this level, we have to go and address this basically.
And I think a lot of labs don't use neutral buffered formalin or they don't check
Yes.
the pH of their
simple,
solution.
yeah,
And that itself causes a lot of variability to the way
And
the
endometrial also, I don't know what is your experience, but endometrial surgical samples, they behave very weird. Though they are surgical, we have like 40, 45 blocks, but none of the block passes
yeah,
DNA.
the endometrials are very problematic.
Very problematic. Yeah.
So I think this large scale awareness and continuous sessions of pre-analytics and how do we treat each step in processing grossing is very essential, like fixation. It will be really helpful. Yes. So current practices, we have again and again heard that all this testing is recommended by NCC and ASCO. So I think you all have already answered that there is a recent change in the clinicians inquiry. So recently here Dr. Anbarsan has not asked us, at least I have not got any inquiries for AKT P10 testing, huh, Dr. Anbarsan?
No, ma'am, no, ma'am. Since the target therapy is not available, we are not requesting for
So,
it, ma'am.
yeah, so targeted treatment is not yet available. So panel of testing also, we have already discussed. So 50% are now actionable, and how readily would the look beyond PIK3CA approach to be adopted in India? So what do you all think? Like how this will take off? Are we
Uh,
very
I
optimistic?
think first the drugs have to be available. Second, it also has to be an affording patient. It's not just the testing being possible. Testing is possible even now, but first the availability of the drug, and second, I think the cost at which it is available will largely drive this test for us, is what I think.
Yes, because most
Also,
of
ma'am, there is a small change in the line of treatment. Previously, we always change the line of treatment based on the patient clinical or radiological progression. If we look beyond PIK3CA, especially for ESR1, in that scenario, probably before say, radiological progression, we need to start. So, clinician, patient, every level, it will be slightly different.
so yes, we mean like theoretically we need even most of the broad-based testing panel all have all these genes. But
Hmm.
like if drug is not available, then what do we do? Do we still
Correct, ma'am. Once drug is available, the next step is like this only. As a clinician, also we need to face a lot of challenge because even without progression, we need to convince the patient for changing the line of treatment.
and also the cost of the drug should be little better, no?
Yeah.
Okay. So with this, I would like to thank you all the panelists for such wonderful discussion and proactive discussion. And thank you organizers, and my request really for the pre-analytic session and awareness regarding the same at frequent intervals.
I
Thank you.
think Empire should take that initiative.
So Dr. Himanshu, Dr.
So,
Srikanth, Dr. Sushant.
yeah. So, thank you, Dr. Trupti, and to all the panelists for a wonderful panel discussion. Okay. Thank you for touching on the issues that are very relevant. And I think many of the attendees would have a takeaway from this that pre-analytical factors, especially at present, as Suruchi mentioned, in lung there is a fixed recommendations of distributing the tissue,
Yeah.
the biopsies, because that has been given as a recommendation or guideline for molecular testing. I think breast cancer also a similar sort of recommendation or guideline would come in as more and more biomarkers for molecular testing would be available. And I would say the key takeaways from the sessions and the panel discussions would be at present, approximately 50% of the patients with hormone receptor positive, HER2 negative advanced breast cancer harbor these biomarkers, especially the PIK3CA mutation, AKT1 alterations, and PTEN alterations. Uh, Both NCCN and ASCO now recommend testing these biomarkers, especially the platform recommended is NGS, and testing for PIK3CA, AKT1, and PTEN alterations at metastasis in breast cancer is important to have an informed targeted therapy decision, especially for medical oncologists who are looking at newer drugs coming up, and slowly and steadily these newer drugs becoming available in India also. So, as we come to close of this enlightening session on PIK3CA and beyond in breast cancer, I would like to extend my heartfelt gratitude to our uh, uh, faculty members, Dr. Anbara Sekar, Dr. M. Santosh Reddy, Dr. Trupti Pai, Dr. Rekha Pai, and Dr. Suruchi Agarwal for accepting our invitation first and sharing their expertise and shedding light on the future molecular targeted testings that we would be seeing in breast cancer beyond PIK3CA. I'm sure the discussion has given a clear sense and idea to the attendees and the opportunities and challenges that actually lie ahead in this rapidly advancing molecular field of genomics that we are not just lung, breast, in other tumors also. A special thanks to the organizing team for putting this webinar together and to our audience for active participation. Coming to questions, there was only one question that was there, and I have already answered it. I would just take it up. A question was there from Vasundhara Singh, and the question was molecular testing is advised and done on formalin fixed tissue if for some reason fresh frozen tissue is not available. So I have already answered it that at present molecular testing in solid tumors is performed on FFP, that is formalin fixed paraffin embedded tumor tissue blocks with adequate tumor cellularity. So, adequate tumor cellularity is very important. And as we discussed, the fixation time, the fixative that is used, the number of cores that are available for molecular testing becomes very important. So, lastly, special thanks to Molecular Pathology Association of India for providing this opportunity and platform to have a discussion of going beyond PIK3CA in breast cancer, the way forward. So, we look forward for a continued discussion and collaboration as we move forward towards future in precision oncology in breast cancer. So, thank you. Thank you to the panelists. Thank you to the speakers and thank you to all the attendees. Thank you very much. Have a good day.
Thank you all.
So, Roshni, we can end the session.